to look for the next presentation. And without further ado, I am delighted to introduce again Professor Mert, the chair of EACTAIC Thoracic Subspecialty Committee from Istanbul University, and he will talk about confirmation of the proper position of bronchial blockers and double-lumen endobronchial tubes. Mert, it is yours.
Thank you very much, Mohamed. Good afternoon, good evening, ladies and gentlemen. My name is Mert from Istanbul. I'm going to talk about confirmation of the proper position of bronchial blockers and double-lumen endobronchial tubes. I don't have any conflict of interest concerning this presentation, and this will be my agenda. First, I'm going to talk about the famous ABC of thoracic anesthesia, and then I will ask an important question. Why is the proper position of the airway device so important in thoracic anesthesia? And finally, I will try to explain some different methods for proper positioning. ABC of thoracic anesthesia. A is for the anatomy. Of course, every anesthetist, but every thoracic anesthetist should be familiar with the anatomy of the bronchial tree, with the unique angulation of the left main bronchus and right main bronchus, the relative high apertura of the right upper bronchus, and possible alterations of this distance between the right upper lobe and the carina. B is for the bronchoscopy. This is how we see the bronchial anatomy through the lumens of left and right double lumen tube. Some tricky things. You have to be aware of the unique vision of the right upper lobe here. This is the only bronchus with 3 further openings, and it's usually called Mercedes star. And this is the vision through the tracheal lumen of the left and right double lumen tubes, how you should see the bronchial cuff in the bronchial lumen. Your bronchoscopic skills should be good enough to have sufficient information about the distance between the carina and the right upper lobe, between the carina and the secondary carina in the left main bronchus. This maybe most importantly, you have to be able to differentiate between the carina and the secondary carina here in the left main bronchus. Less experienced colleagues, I would say more common than expected, would say with this view that they would see the carina, the primary carina, and this confusion would lead to a totally misplaced double lumen tube. That's why actually we organize now and often workshops for the fiber optic bronchoscopy to make people familiarized with the fiber optic bronchoscopy. And C is for the chest X-ray. This is probably one of the most famous chest X-rays. It's from a study of Peter Slinger from a paper. And interestingly, it was only the anesthetists who have recognized here the problems with the trachea, and we can foresee that there will be some problems regarding the airway management in this patient if we have such a carina. Interestingly, all the other colleagues from the other disciplines have focused on the mass here on the left lung. The chest X-ray can help you also for your decision about the size of the double lumen tube, and sometimes about how far you should approximately insert your double lumen tube to. So this was the ABC, and probably we will have some other letters too, and I will inform you about the next letter in the next slides. The next question is, why is it so important to have a proper positioning of the airway device? In 1970s, hypoxemia was a very common and very important, very challenging problem of one lung ventilation. This is Peter Slinger, by the way. It was assumed that shunt was the most probable reason of hypoxemia. Of course, shunt is still a very important and very common reason, but we have seen that probably the inappropriate position of the airway device was a more common and important reason. Even better, there's a chance actually because you can solve this problem in a much easier way than dealing with intrapulmonary shunt. In several studies during the millennium period, it has been shown that indeed double-lumen mouth tube bound position was a very common reason of hypoxemia during one-lung ventilation. In patients with double-lumen tube mouth position during one-lung ventilation, an intervention to treat or to prevent hypoxemia has been shown to be more common. So, as it is so important, we can discuss about the different methods of proper positioning. The historical answer for this is auscultation, but this is just historical. This study has shown that in as high as 40% of all patients, the double-lumen tube is not in a correct position, although your clinical judgment with auscultation was okay. And that's an explanation why the frequency of hypoxemia in these years was so high. And therefore, now we have to find something else to make a more rational decision about the proper position of the double-lumen tube or bronchial blocker. So auscultation is not the answer. The second one is the fiber optic bronchoscopy. Fiber optic bronchoscopy is still the gold standard for proper positioning of the double-lumen tube and the bronchial blocker. If I proceed short, this is what you see through the bronchial lumen of now the bronchial lumen of the left double-lumen tube. And this is what you see now through the tracheal lumen. You can see here the bifurcation. And this is what you see here through the tracheal lumen. This double-lumen tube is now in a proper position. You can see the inflated balloon here, and you can see also the so-called teardrops, which you would say that the bronchus was sealed in a good way. Sorry. This is what you would see via a right double-lumen tube. Let's go a little fast. As you can see, our bronchial lumen is going to the right main bronchus. The tricky thing here is, here you can see a lateral eye. First, you can adjust the tracheal lumen in a good way, but afterwards, you have to adjust again in this lateral eye, the aperture of the right main bronchus, as you can see here. And afterwards, you have to check again the proper position of the of all the double-lumen tube. It can be the case depending on the variations of the right upper lumen, right upper lobe. This can be problematic. So this study of White Karzai, our friend, has shown that in A, we are in a proper position for both left and right double-lumen tube. In B, the double-lumen tube is too far inserted. In C, too high inserted. And in D, we have the bronchial lumen in a wrong main bronchus. Obviously, we have a margin of safety here, but this margin of safety is quite limited, especially if you are dealing with the right-sided tube. The margin of safety is very limited. Therefore, you would need a fiber optic bronchoscopy. You would need a fiber optic bronchoscopy after intubation, after positioning the patient to the lateral decubitus, after change in oxygenation and change in ventilation pressures. then we have the bronchial blockers. We have the Cohen, the one with the hockey stick with the angulation at the distal tip and the easy blocker. This is not the topic of today. And why do I need a bronchial blocker? Actually, your thoracic surgeon will probably claim, and he or she wouldn't like it if you use a bronchial blocker. That's because the anesthetist has less experience and he's less familiar with the bronchial blocker. There are actually cases where a bronchial blocker would be indicated. In a difficult airway, if you have a difficult intubation, this will be even more difficult if you use a tough and hard double-lumen tube and thick. If you have a difficult lower airway, like it is here in this case, it will be again very problematic to use a double-lumen tube here. If you want to have a selective lobar blockade, this was a patient with hydrated chest, you would like to have a selective lobar blockade. You can here see the ventilation of the upper lobe. In children, using double-lumen tube would be very problematic and very difficult. We prefer always bronchial blockers, and we prefer always bronchial blockers with hockey stick tips. These types of blockers are very easy to use, especially in children. If you have difficult intubation because of, let's say, ankylosing spondylosis, like it is in this case, you have to intubate your patient awake with fiber optic bronchoscopy, and you have to use afterwards a blocker like it is here. Or if you have a patient with tracheostomy, you can still have double-lumen tracheostomy cannulas, but these are very rigid and not easy to handle. We prefer always using bronchial blockers. This is how it looks with the bronchial blocker. You can see through the lumen that the bronchial blocker, this is a bronchial blocker with a hockey stick tip. And the angle at the tip of the blocker enables you to direct the blocker to the lung that you want to block. It was, as you can see, in the left main bronchus, and it is very easy with a rotation to direct it back to the right main bronchus. It's always a good idea, I would suggest, to see the inflation also under fiber optic bronchoscopy control, because in that way you can be sure about the correct positioning of your bronchial blocker. And moreover, as you can see here, you can be sure how much volume, this is a very common question, how much volume do I need to block with a bronchial blocker? For me, the perfect answer is see. Just see and judge for yourself. This is now the correct positioning, and it is now sealed. The correct sealing of the lung with bronchial blocker. Another method can be the continuous visualization with the embedded camera. This embedded camera can be with a double-lumen tube, as you can see here. This is a photo from our friend Manuel Gil from Valencia, or it can be also at the tip of the single-lumen tube, and then we can use it with a bronchial blocker again. These have several benefits, especially an decreased use of fiber optic bronchoscopy, and this can be also especially significant these days in COVID days. The Thoracic Subcommittee has published 2 papers about airway management and thoracic anesthesia procedure in COVID patients. And in these cases, I don't want you to misunderstand me. I don't say that you don't have to use the fiber optic bronchoscopy anymore, but the need for the fiber optic bronchoscopy is decreased if you use a double-lumen tube with an embedded camera. It can be used in robotic surgery, and in cases that you would like to see the position of bronchial blocker continuously, this can be also a good idea.